In the slides that I've given you guys, there's some like summary slides, right? Use those slides to help kind of get that brainstorm going when you're studying. All right, so.
Asked about reviews. I don't know if we're going to do one or not. Depending on our time, we may or may not do it.
All right. So part 3 today, we're going over opioids. How do we feel about opioids? Okay, if we don't have any sarcasm, how do we feel about it? Not too good, a little hesitant maybe? Okay. Do we think they work?
Yes.
Okay, they work. What type of pain do they work for?
Severe.
Severe pain?
Cancer.
And cancer, okay, those are going to be our go-to. So if someone, right, think back to good old Scott, right, axial chronic low back pain, opioids really don't show good functional benefit. What do I mean when I say functional benefit? Yeah, someone's pain might go from a 5 to a 4, but he's not doing anything else with that. Okay, so chronic pain, our goal is always functional benefit, and so opioids in terms of chronic pain that is not cancer-related, bottom line up front is very much that they don't have a place. Disclosures again, these are my viewpoints. I guess if they're there. As we go through stuff today, we're kind of going to jump between concepts, but I spent a lot of time trying to figure out what would make the most sense. And so while it might seem a little confusing at first, I hope that it does make sense as we continue to add more and more concepts to this. Again, when looking through all the options that we have, opioids are kind of on the bottom here. Again, except in what situation?
Cancer.
Not just cancer, but severe cancer. Perfect. All right, lots of abbreviations. So our controlled statuses, we went through day 1 on Monday. All right, we have C1s. They're illicit. We can't use them. The opioid that is in that group would be heroin. C2s are going to be the majority of our opioids. Okay? Codeine by itself is a C2. You can jump ahead and see codeine with Tylenol is a C3. The brand name of that commonly we refer to as Tylenol number 3 because it's 30 and 300. And it's one way that you can remember that that was a C3. Okay, buprenorphine is also a C3, is one of our opioids. Tramadol is a C4, and then in our C5s, when we have codeine but we mix it with one of our expectorants, now we get it as a C5. So how does understanding how opioids are metabolized help us? Why are we starting in the middle of our typical, right, we're not starting with mechanism and all that stuff. Why are we starting with metabolism? Okay, there's some like pharmacokinetic properties that are coming up. So chemically, the biochem folks are chiming in now, right? Chemically, they all align. Okay, so most of them are going to look like that first category there. Opium, which is where we have our opiates. So opiate means that it's derived from opium. Morphine is going to be that option. Okay, other things that are like morphine are going to be opiates that we see in that first category. So the ones in that first column that don't have an asterisk are opiates. Opioid is something that is resembling opium, but is not an opiate. So it has those same effects, but it doesn't look like opium does. When we think about cross-sensitivity, okay, if you're deathly allergic to one, we look at the chemical structure. And we say, if you're deathly allergic to this one, you're probably not deathly allergic to that one. So you can see on the bottom there, as we go further and further away from that, we have less of that risk of sensitivity between these different chemicals here. The metabolism is all connected. Okay? So our opiates, we see in this top part up here. So codeine goes to morphine. Heroin also goes to morphine. Okay. Heroin also goes to a metabolite that we nickname 6-AM, and that is metabolized to morphine. Okay. So if someone has a positive morphine, what drugs could they have taken?
Codeine, heroin.
Codeine, heroin, or 6-AM is not a drug, unfortunately. What else could they have taken? Morphine. Right? We're thinking too far ahead. Okay?
Got us.
Alright, codeine, while it does go to morphine and that's its main metabolism pathway, it does also go to hydrocodone. Okay, morphine goes to hydromorphone. I love that we named them so wonderfully, okay? So here's my little cheat sheet, just the first letters on the side here. We see heroin, it goes to 6-AM. That goes down to morphine. We see codeine goes to morphine. Codeine goes to hydrocodone. Morphine goes to hydromorphone. Hydrocodone goes to hydromorphone. Okay? So if someone is deathly allergic to any one of those, we can't give them anything upstream of it. Okay? We might be able to give them something downstream, but we don't know what part they're allergic to. Okay, when we go to our oxys, they also have the same naming regimen. So oxycodone goes to oxymorphone. Okay. When we look back at our beautiful pictures here, the ones that we just talked about are all the ones in that first column. Everything else looks a lot different. And so those metabolism pathways are kind of all independent on themselves as well. Okay? So tramadol doesn't fit in there, fentanyl doesn't fit in. They're all in those different columns. So they're not going to be in that same picture, that same cycle as the other ones. As we go through this pathway, it's also important to think about what metabolites that they have. This is another way of looking at that last picture. So we see the two yellow columns. The first yellow column are all of the opioids and what they turn into. Okay, so we see morphine on the top. We see that it has an inactive metabolite. I don't care about that. We see that it has an active metabolite that is a pharmaceutical product, which is hydromorphone. Okay? It does also have other active metabolites that are doing action, but aren't available to be given as a drug. Okay? So for morphine, we have N3G, we have glucuronides, and N6G, which we'll talk about when we talk about morphine. Those are going to be the main drivers of our side effect profile. Okay? So the takeaways here is that we have drugs that are active, they go to other drugs that are active. Okay? Not all the drugs do that. There are two drugs that are metabolized solely to inactive metabolites. What two are they? Fentanyl, methadone. So what drug interactions are we going to be concerned about with them? What if we have a drug interaction that stops metabolism, that inhibits metabolism? You keep taking the drug, but that drug isn't becoming inactivated. Okay. So those are going to be our drug interactions. Our big two that are going to have a ton of drug interactions and concern is whenever we're going to add a medication to those folks, we need to make sure that they're not being inhibited in their metabolism. As a friendly refresher, right? Our 3A4 metabolisms are up there. I don't know why that was animated. So our 3A4 substrates, the opioids that we commonly think of, are going to be oxycodone, methadone, tramadol, and fentanyl for 3A4. The ones that we commonly think of for 2D6, our second most common CYP enzyme that we're using is going to be codeine, tramadol, hydrocodone, oxycodone, and methadone. All right, we're going to start strong with Edward. I have a lot more cases today. I think that is helpful for your guys to be learning it that way. So Edward is a 45-year-old male. He has a short course of tramadol therapy. He was notified by his employer that he has been randomly selected for a toxicology screen. When you have workplace toxicology screens, they typically do what is called the Federal 5. And it looks for these 5 components here on the bottom. They're all pending at present. How do we think they're going to result?
Negative?
And negative, why?
Tramadol doesn't break down any of those.
Yeah. So tramadol is an opioid, but it is not an opiate. It does not resemble the appearance or the chemical structure of opium. So what drugs would he have to be taking for that to be positive? Morphine.
Oxy. Heroin.
Oxy semi-synthetic. So all the ones that are in that top morphine pathway, okay? So heroin, morphine, codeine, hydrocodone, hydromorphone. Those are your most opiate like. All right, Marissa. She's a 44-year-old female. She's receiving chronic opioid therapy, and she's on methadone 10, PID, and oxycodone IR 5 milligrams, P4, PRN. She had a toxicology screen that was done via urine and was recently completed, and these are the following results. What is your interpretation of these results?
Fine.
Thumbs up, thumbs down. Who says it's fine? Love it. Send it. Who says it's not fine? Okay, so a few more that say not fine. Why not fine? Okay, methadone doesn't have any active metabolites. So should methadone be present? Yes. Okay, so we're good at that one.
Oxymorphine's fine, but then
so oxycodone, should that be positive? Yes. Oxymorphone, should that be positive?
Yes.
Yes.
Hydromorphone.
Right. So oxymorphone is a metabolite of oxycodone. Hydromorphone?
No.
No. Okay. So hydrocodone, she could have taken hydrocodone. Could she have taken anything else to get a positive hydromorphone result?
Codeine. Heroin.
Not necessarily. So there's two criteria here, right? So the morphine is not present, undetectable. So what's the only other thing that she could have taken?
Hydrocodone?
Hydrocodone. Right? You guys got this. Right? Well, jigsaw puzzle right here. Okay. So this is very much based on a case that we had yesterday in pain clinic. One of the doctors was asking me, like, any way that this could have happened. And so thankfully was able to sleep on it. I'm actually visiting with them right now, so I'll be interested to see what happens. But most likely, my hope is that she went to the ER, had a procedure done, or was in pain or something. They gave her just a one-time dose of Dilaudid, or IV hydromorphone, and that's why it's positive. That's what we're hoping. Questions? All right, how do opioids work? We'll go back to the top. So opioids work, they're agonistic, they activate the receptors. When they do that, they cause pain relief, they also cause sedation, they lead to respiratory depression, they can cause euphoria, and they can result in physical dependence. Based on the type of opioid receptor that we are activating, we can get additional outcomes. Okay, so mu receptors are super common to have meiosis, or constriction of the pupils. Mu receptors are also responsible for the constipating effects that we get. When we have constipation, it's because we have mu receptors that are lining the gut, and when they are blocked, we have no more motility. So our gut literally just pauses. How can we treat that? How can we speed up the gut? Stimulate it, okay? So that's an important reminder. Do we give them a softener?
No.
That's not gonna fix what's happening, right? We need to stimulate the bowel, okay? Mu opioid receptor activation also has histaminergic responses. So folks who are taking opioids that are highly mu opioid are gonna have more likely to be itchy from it, to have vasodilation, to have any of our stereotypical histaminergic responses. And then kappa activation can cause dysphoria. Unfortunately, not all opioids are created equal, or maybe fortunately, I'll rephrase. And so we have different actions at each of these processes, okay? So an agonist, a partial agonist, an antagonist, or an inverse agonist. I like to think of this like a saloon door, okay? Or like a kitchen door, right? It goes both ways. So one way, I'm going in, I'm opening up the doors all the way, I'm an agonist to that process. They're fully open, I'm activating that receptor, we're going. A partial agonist, I'm just opening up one of them, okay, not the whole process is happening, we're just getting a little of that flow come in. So of our side effect, or of our mechanisms, we won't be getting all of those mechanisms. Similarly, side effect wise, we're not going to get all of those side effects. So a partial agonist can be really helpful. An antagonist just sits there. It doesn't do anything. It just sits there, it occupies the space, it just stands at the door, nothing's going in but nothing's coming out. Okay? An inverse agonist is doing the opposite. You're opening the door backwards, people are now flooding the other way type thing. Okay, so you're doing the opposite of the mechanism that we would be doing should we have been activating that receptor. We're doing the exact opposite. Okay, so remember that antagonists are just blocking it. Inverse agonists are doing the opposite of that receptor. Agonists have no ceiling effects, meaning the more and more you give, the more and more things are going to keep happening. That means that with higher dosing, you're going to increase your risk of having an overdose. Common examples that are full agonists are going to be morphine, oxycodone, fentanyl, and methadone, all of those being at the mu opioid receptor. We have one that is a partial agonist at mu. It's going to be buprenorphine. Again, it's partially going to activate that receptor. It has ceiling effects, and how I like to think of is that it helps, it's a moderation. Okay? Not everything's happening, but some stuff is happening. Antagonists occupy that receptor and they block both positive and negative signaling. So naloxone and naltrexone are two examples of that. And then an inverse agonist, buprenorphine at kappa, does the opposite of that receptor. So looking at the last slide, what was the mechanism at kappa? Dysphoria. So what do we think is going to be happening when someone takes bupe?
Euphoria?
So they're not going to feel, see elephants and all those things. Right? We lose that effect. Okay. Same thing, it's also a partial agonist at mu. So looking back at all of those mechanisms, we're not going to do it to the same extreme. So question being nausea and vomiting. Okay. I would say the majority is going to be mu for that, but they all do touch on it. Delta we don't know a whole lot about, unfortunately, but kappa and mu by far are our most common ones. That was it. Question? Alright, so this is how they're working. The other thing we need to think about is the affinity that they have to the opioid receptors. So this tells us how tightly it binds on, how big of a hug it gives that receptor. If it was a magnet, how tightly is it sitting there? The lower the number, the tighter it's there. It does not want to come off. Okay? So the higher number, the more likely it is to disassociate and say, oh, hey, I'm going to head over here. Okay? So if you were going to give everyone all of these drugs, which one is going to be on the receptor? Buprenorphine. Okay, it has the highest affinity, the highest binding to opioid receptors. Anything that has a stronger affinity will displace other things. All right, further mechanism. So we're going to activate our descending pain pathways, inhibit that nociception transmission, and then alter the pain perception. So all three of those areas are where opioids have action. Example-wise, we can have closure of that calcium channels presynaptically, and we can actually have potassium efflux, causing that hyperpolarization. Our bodies naturally have opioids. Okay, if you get hurt, it'd be nice if your body could make something to help protect that. So we have endogenous opioids. They bind to our opioid receptors, and that's what we're going to be using for ourselves when we're in pain. If we take a bunch of opioids, our body doesn't need to make its own anymore. So we have downregulates our endogenous opioids. So if your body's not making any more opioids because you're taking opioids, and you were to stop taking opioids, how are you going to feel? Not great. You're not going to be able to cope very well, right? Because your body's not able to keep up and make those endogenous opioids anymore. Okay. We're getting it? We're getting through it? Okay, well, in case this hand is up. Side effect-wise, these are just broken down. So respiratory depression, this is our most serious one, it is fatal. Okay, as we continue to take opioids, the concern is that we will eventually have respiratory depression, and that will be fatal. We have CNS depression. We can actually counter this by giving them a stimulant. Again, this isn't going to be in Scott, our patient, who's chronic low back pain, right? But maybe one of our folks that has cancer are complaining of these types of symptoms. Meiosis is something that we don't grow out of, okay, with increased opioid dosing. Histamine release, again, it's going to be more of that mu opioid receptor. Constipation is another one that we don't grow out of. The longer we take it, we don't get that tolerance to it. So we do need to manage it. Again, that's because that gut's not moving. We need to stimulate it along. We can also use a local opioid antagonist. Tell me what that means. Local versus central.
Stopping it from binding in the stomach.
Local versus central, or centrally acting in the brain, okay? Local would mean in the gut. So we want a local thing that is an opioid antagonist. So what's it doing? Sitting there, it's occupying that receptor. Okay, so then the opioid that normally would bind there and say, hey gut, stop moving, it's not able to. Okay. Nausea and vomiting, seen again in those 30 to 60% of cases. Typically, as folks continue to take this, they are able to get past that. Otherwise, we can give them antiemetics if we need to. Some folks can get CNS seizure development would be something that we're really concerned about. The longer they're taking it, the higher the doses they're taking, all of those things. Some of our opioids we'll chat about also have serotonergic effects. Okay? Those also have a seizure risk in and of themselves. Opioid-induced hyperalgesia is an interesting concept. What is hyperalgesia? Intense pain from
your senses?
So let me give you two midterms here. So hyperalgesia versus allodynia. So they're both increased pain. Yeah, so hyperalgesia is I punch you, it hurts, but now it hurts 10 times more. Allodynia is from a non-noxious stimuli, meaning I brush a feather on you and you are crying in pain. Okay, something that is not painful is painful. So hyperalgesia is the pain that is normally super painful is even more painful. So how this looks is we give folks opioids. They're like, yeah, my pain sucks. Yeah, it's bad. Okay, well we can treat that. Let's increase your dose. Well, my pain is still really bad. You know, it kind of hurts more. Well, let's increase your dose. My pain is unbearable. So how do we treat it? We decrease the dose. So it's something that's dose related. So it's a very interesting concept that will get folks that come by and they've just been increasing that dose for years and years and years, or weeks and weeks pretty much. And then we'll end up seeing them realizing that they probably have hyperalgesia from that opioid escalation, and we just need to reduce that dose. It's a very interesting concept. We can also try to switch to another opioid, something that has a little bit different of a chemical structure, to see if they don't have that same response to another one. Overall though, our opioids are going to be sedating, they're going to make us dizzy, they're going to have that respiratory depression, nausea, vomiting, and then constipation, again, more at that mu opioid receptor. Long-term side effects. Okay, these are great counseling points for your patients. They're like, yeah, I'll just stay on it. Well, did you know that your libido can actually get out of this? Your mood is often worse, right? You don't have that, and your endogenous opioids aren't there. They're not able to bind and activate those good healing areas. We increase our fracture risk. So, I know we talked about on day one, number needed to harm, right? How many people do we need to give a drug to in order for one person to have a negative outcome? So fractures with opioid use is 25. So if we give opioids to 25 people, one person will have a fracture. Okay. That's pretty significant. Acutely, so that's in chronic use, acutely, their fracture risk is about 3 times. Again, I'm going to ask you that number on the exam now, just for your knowledge. All right, immunosuppression, another big thing. So the risk, or the number needed to harm for community-acquired pneumonia is 16. So another fairly high number. And then increased cardiovascular risk. So having any sort of heart attack, stroke increases 2.4-fold. So over double when you're on opioid therapy. How do we minimize these concerns? So we can dose reduce. We can rotate to something else. I always like to think that rotating, we can think of cross-tolerance, which we'll talk about here. But when we rotate, our body's not used to this new chemical, even if it's in the same family tree. Okay? It's a new chemical that your body's not used to. If you're drinking coffee and then you go over to energy drinks, you're probably going to feel a little bit different, right? Your body's going to react to it a little bit in a different way. Maybe there's a little bit more sugar here, a little bit more there, but at the end of the day, it's still caffeine. Okay, so we can typically dose reduce when we go to another product. We can try a different route. So maybe in one route they get a side effect where in another route they might not. Intrathecally would be one example that we're not going to have as much GI side effects if we're infusing it straight into their CNS. And then symptomatic management. So if they're having itching, if they're having rash, we can give them an antihistamine. If they're having nausea, we can give them something for that. Okay. Methylnaltrexone, or Relistor, is going to be an opioid antagonist. It's going to work locally. Methyl is a little arm that is added on to, we'll talk about naltrexone later, but methyl is going to make it bigger. Because of that, it's not going to want to cross into the brain. It can't cross that blood-brain barrier. Okay, so it's only going to stay in the periphery. Our opioids are going to be working centrally. So if we have a drug that's only in the periphery, it's going to help us if someone has opioid-induced constipation. Okay? Just like we just talked about. It's going to sit on those receptors, those opioids can't bind to those receptors anymore, and we're able to have that motility maintained. Unfortunately, methylnaltrexone is extremely expensive. So it's about $100 a day if they're taking it orally, or $200 a day if they're taking it sub-Q. Alright. So thinking about all those fun side effects. Harold, 63, I don't know why I have only 40 and 60-year-olds today. 63-year-old newly initiated on opioid therapy for severe cancer-related pain. He wants to ensure that he will be able to maintain a high quality of life and minimize potential concerns associated with therapy. So firstly, is opioid therapy appropriate?
Yes.
Yeah. Okay, severe cancer-related pain. What are some things that we might want to counsel him on? Sedation, side effects?
Cost.
Okay. Drug interactions potentially, depending on which opioid he's given.
Medical
Okay.
history to see if he has like some sort of hepatic or liver issue?
Yeah, good. Is any hepatic or renal stuff going on? Constipation? Yeah, okay. What things can we use for his constipation? Methyl naltrexone, stimulant laxative, okay? Or we could dose reduce, all of those types of things as well, okay? All right. These three words we, again, talked about on Monday. So tolerance. Tolerance is that you use it to a point that if you were to, it resets your baseline. And then you keep using it and you just need a little bit more to get back to that baseline and a little bit more. So this is, you started with 1 cup of coffee, now you need 2, now you're up to 3, so that's your tolerance. Okay, your baseline keeps resetting. Dependence is that at that dose, you need it. You need it to function, you need to be stable. If you were to stop it, you would see withdrawal. Addiction is using it despite the negative outcomes, cravings, behaviors, all of those pieces. When folks are given opioids and they unfortunately develop a state of addiction, we call that opioid use disorder. Okay. There are 3 treatments that we can use in the setting of opioid use disorder. One is methadone. It's an agonist at mu. What is that going to do for us? I'm addicted to opioids. Let's say it's heroin. I am addicted to heroin. Now you're going to give me a mu agonist. Is it going to make me feel good, feel bad? Is it going to counter effects of heroin?
You're not going to have this anymore, right?
It's gonna occupy and what? Not just occupy. We're opening the door. Okay, so we're essentially replacing heroin for methadone. Okay, they're both agonists. They're both working at that site. Okay, for opioid use disorder, the only way that you can get methadone for that indication is to go to an outpatient treatment program. Have we heard of these? Yes. Okay, so this is every single day, you're going, you're getting your little cup, it's really like Kool-Aid. They kind of just dispense it. Whatever dose you're on, you drink it in front of them, and then you leave. Okay? So that's how we use methadone. Buprenorphine is going to be a partial agonist. So what's that going to look like? How's my door looking? One door's open, okay? So I'm getting some effects. I'm still getting kind of treated. So hopefully my pain is controlled, my cravings are controlled, but also hopefully I'm not getting the sedation, the grogginess, all of those other side effects that we think about when both doors are fully open. These have been historically, or buprenorphine has historically been tied to X waivers. But more recently, that was essentially reversed with the MAP Act, which we'll talk about on the next page. Naltrexone, without the methyl group, acts centrally. It's an opioid antagonist. So now the door is closed. So now if I use heroin, no. How we use this for opioid use disorder is going to be an intramuscular monthly injection. Some people may need that a little bit sooner, but the main thing is that we're trying to inhibit cravings with it. Per the VA guidelines, as we look at for treatment of chronic pain and chronic pain has opioid therapy, and then in this recommendation for opioid use disorder, there's no specific recommendation as far as which one to choose. Okay, as long as you choose any of them, that's what's encouraged. So first we'll talk about that X waiver. So the X waiver was with Bu. So back in 2000, they set rules that if we're going to treat opioid use disorder for any C3s, 4s, or 5s, that they must have this waiver, meaning the providers must get this additional training through the DEA, apply for this additional license, if you will, to be able to treat folks that are on view, that are getting it for opioid use disorder. Methadone's at C2, so it didn't fall under this program. In 2021, they said, you know what, we don't have to really do that, okay? I think COVID actually did us a big favor in this process here by saying, no, this is a lot of hassle, and folks aren't getting worse, so how about we keep treating them? Then 2 years ago here, they realized that we were actually stigmatizing these folks, okay? And so they eliminated the need for the waiver. Anyone can treat anyone that has opioid use disorder with you. There is a extra training that is required, or that is just part of the normal DEA license renewal process now that everyone has to take. Okay, so anyone can use you for opioid use disorder now. Naltrexone, or Vivitrol, is the injection. It's going to be a central new opioid receptor antagonist, so it's going to be working on the brain, on all those craving sites. We can use it for opioid use disorder. We can actually also use it for alcohol use disorder. Does alcohol hit mu receptors? It actually doesn't.
Is it just associated with craving?
Somewhat, yeah. So our body, when we have alcohol and everything feels good, our body releases our feel-good little chemicals, our endogenous opioids, and they're like, yeah, this feels good. I like it. Keep it up. If we block our own body from being able to have our endogenous opioids, hit those receptors, when we drink alcohol, it just doesn't feel as good as it did before. So that's how we can use it in alcohol use disorder. Low dose naltrexone we talked a little bit about yesterday. And so the thought is that if we just give a very tiny dose, we'll be able to upregulate the amount of available opioid receptors that then can be activated by either prescription opioids, illicit opioids, or your endogenous opioids. All right, oral for a month, okay, very different pricing. You take an oral dose every 1 to 3 days, and again, that's going to be for alcohol use disorder. The monthly injection is about $2,000. So it is fairly expensive. So of our 3 options, methadone is very cheap, so you have to go in for it. You, kind of expensive. Naltrexone, you have to get an injection once a month, pretty expensive. Other things to think about is that we don't want somebody to go through withdrawal. Okay? If someone has gone through, they've come off their opioids, but they just still have that craving, this would be a great option for them. They still have opioid use disorder, and we can manage that. We can sit on those receptors so they don't get that feel good anymore. And so what we want to make sure is that they have fully withdrawn. They have that window, they are detoxed from opioids. We don't want to be throwing them into a withdrawal, if you will, by giving them this injection that we can't reverse. Because of that, we want to make sure that we're ensuring effective pain management. So if someone does have a painful surgery or procedure that's coming up, they need to be mindful of that, and maybe we need to do something else to help bridge them. Okay, so if they have a surgery that's coming up and it's within the month, we're going to probably have to overcome the effects of the naltrexone that's in the system by giving them significant amounts of opioids. Okay. You may consider encouraging your patients to have a medical bracelet. Okay, if they were in a car accident or something, and we give them a push dose of opioid and they're still screaming, and we give them another dose and another dose and another dose, we might just need to start higher, and if we know that they're on naltrexone, that might be more helpful for our folks that are treating folks that have this condition, that are on this medication. Alright. Tony. Tony's a 75-year-old. He's been newly diagnosed with metastatic cancer. He's been offered opioid therapy to manage his severe cancer-related pain, though declined, stating, I don't want to get addicted to that stuff. a weekly occurrence. What does addiction mean?
Yeah, what about?
Despite negative outcome.
Using it despite all those negative outcomes and harms. What's likely Tony going to experience
Reduce pain.
if we give him opioids? Dependence and tolerance. Right? You know what, Tony? I hear this a lot. I wouldn't be surprised if when we give you this, your body responds to it, and after a little bit, we actually need to increase it. Okay? That just means that your body's getting tolerant to it. And I've also seen a lot of my patients that if you were to ever stop this, you're not going to feel that great, and you're going to have some withdrawal. That's also really common. That's what we call dependence. Okay? I'm not concerned that you're going to get addicted to this product, because we're going to have a really good relationship, and I'm going to ask you a lot of questions, and we're going to do a lot of assessments to see if you meet that criteria. If you do, we will work with you, we will treat that. All right, Kenzie. She's a 30-year-old female, opioid use disorder, interested in trialing something to help mitigate her ongoing cravings. Okay, only hearing naltrexone, just, right? What does she want, right? How involved does she want to be? Is she insured? Okay. Can we give her methyl naltrexone? You guys got it, right? They're like, oh, what's the exam option's going to be? How am I going to get tricked up? So why can we not give her methyl naltrexone? It doesn't go into the CNS. Okay, methyl is bigger. We only want naltrexone. Okay, naltrexone will cross into the blood-brain barrier. So we can do naltrexone, IM injection once a month. What else can we do? Bupe. Who can prescribe it? Anyone who has a DEA? Okay. Or methadone. How does she have to get treatment for that?
Clinic.
Has to go into that treatment center. Okay. All right, some precautions that we need to be mindful of. So patients that have impaired pulmonary function, right? Opioids reduce or have that respiratory depression aspect. So if they already have poor respiratory drive, that's not going to be a great combination. Right? Someone who has severe COPD, horrible asthma, repetitive pneumonias, patients that have head injuries are another population. Opioid therapy can lead to that respiratory depression, meaning that we have more of that carbon dioxide hanging around. That will then cause vasodilation within the brain and then more damage. In pregnancy, the concern is that mom would be giving birth to a child that potentially is addicted at birth or dependent at birth, right, on opioid therapy. It is potentially fatal in the newborn. That is the only population that coming off of opioids is fatal. Is someone who cannot compensate for those withdrawal effects. Oftentimes, prior to birth, we'll try to wean mom a little bit so that it gets less in their system. We can also give products to babe when they're born. So morphine, bupe are common things that we can give after birth. But a lot of kind of kangaroo care, skin-to-skin type things, soothing techniques, sugar, they're all in the guidelines of how we treat our neonatal withdrawals. In lactation, opioid therapy can be present in breast milk, meaning that if we give it to our kiddo, they can also develop respiratory depression. Codeine and tramadol are two that, if someone is a rapid metabolizer of 2D6, both of those go to a more active metabolite. Codeine goes to what? Morphine. C goes to M. Okay. Tramadol, I don't care if you guys know what that metabolite is called, so I didn't tell you, but it has a more potent metabolite as well. Okay. In peds, same thing. Codeine and tramadol, we are concerned in our ultra-rapid metabolizer groups. So there is a box warning for codeine. Anyone who's under 18, if they're having tonsils or their adenoids, any sort of surgery there. Contraindication, if it's tramadol, under 18. Contraindication with both of those less than 12 in any scenario. And there's a warning for those 12 to 18 if someone is at high risk of having an opioid overdose related event. Okay, if they're obese, if they have sleep apnea, if they have lung disease, or bleeding problems. Renal and hepatic was also mentioned. Okay? So all opioids carry risks for accumulation in both renal and hepatic, and some more than others. So this is a little snippet of some of those things that we think of when we think of those that are going to be preferred in renal failure. So butyl, hydromorphone, methadone, pentothal, and then those that we prefer in hepatic failure. Which one is in both of those as a preferred agent? Fentanyl. Okay. Which one is an unfavorable one or an avoid in both categories? Codeine. Everything else falls somewhere else. Little Milo, 10-year-old. He's going to have some extensive dental procedures that are done. It's expected to be severe and persist for a few days following the procedure. He's going to do some non-pharm things like cool compression and rest. But we're thinking maybe he might need an opioid. Okay, it's a short procedure. It's going to be really severe. We know that there's a deadline to it. What are our thoughts? Just dealer's choice. Beautiful. Don't use codeine, don't use tramadol. Why?
Contraindicated?
Yeah. You have a contraindication. In which age group does he qualify? Less than 12 is a contraindication. Right? So anyone less than 12 for both of those. And then depending on what dental procedure he's getting, technically he could have a box warning if it's codeine or another contraindication. Okay. All right, we have a REMS program for all of our opioid products that require that manufacturers give good information out. We also have a handful of box warnings. Okay, so warnings for addiction and misuse, for respiratory depression, for accidental ingestion, neonatal withdrawal, like we mentioned. So again, that's going to be when they're born. And then concurrent risks with other benzos or CNS depressants. Opioid overdose can lead to death. Okay? Overdose leads to death. Does withdrawal in an adult human lead to death?
No.
No. Does it feel like it?
Yes.
Yes. Okay. So the more and more and more opioid we take, the more likely what is going to eventually happen?
Death.
Respiratory depression and then death. Okay? So risk factors for having an opioid overdose is if they've had one in the past or if they've previously been intoxicated by it. If they have a substance use disorder or if they use illicit drugs. If they're on another CNS depressant, if their opioid dose is above a certain threshold, so this is 50, and we'll talk about what that number means. The 50 and above has 2 times the risk of overdose as those that are less than on a dose of 20. Okay. If they have respiratory compromise at baseline, and then renal and hepatic impairments. Overdose looks like what's in the chart here, but it's that slow and shallow breathing or no respirations. Difficult to arouse or awaken. They have those pinpoint pupils. I'm gonna do lips and fingertips. When this happens, how much time do we have? It's fine, just, get someone, okay, for this person to be sure of it, breathe, trace it.
Immediate response.
Yeah, we need some rapid reversal. How are we gonna reverse the effects of opioids?
Okay.
Right? Currently, we're sitting on those receptors, we're saying, hey guys, we're open. Right? We don't want to do that anymore. So what do we need to do? We need an antagonist. So our rapid reversal agents, their primary mechanism is going to be a mu antagonist. They compete for that mu receptor, displacing those opioids based on that affinity. They're primarily going to be used in opioid reversal. There are things that oftentimes patients will be cautious of being like, what do you mean I need that? Right? And so trying to figure out what your script is going to be for, you know what? I hope you never have to use this. Okay? I hope you never have to use a fire extinguisher. You know what? Whenever there's a fire, you're really happy to know that there's a fire extinguisher nearby. That's the same thing here. For folks that have allergies to something or who have an EpiPen, I use that same analogy. Right? I hope you never have to use your EpiPen. Right? This is just like that. If it does ever happen though, I really want you to make sure that you have one. It's going to be helpful for those that have those risk factors that we talked about, as well as those that live more off the grid, more remotely. Okay, it's going to take longer for EMS or someone to get to them. Commonly, these are going to be given to patients intranasally for their own use. We do also have intramuscular, and then we can administer via sub-Q or IV as well. Side effects are going to mirror that of opioid withdrawal. So they're going to feel not great. Myalgias, GI, more of that diarrhea, they're going to be irritable. The approach, and this is the outline for nasal administration. Yeah. Can I have 4 more minutes? You don't have to. You guys tell me. 4 minutes. Okay. Rapid reversal. So the approach for nasal, these are going to follow these pictures right here. So we're going to evaluate the patient. Hey, are you okay? Flashbacks to those modules. Okay, we're going to see, has their breathing slowed? What do their pupils look like? We're going to administer the first dose. Okay, they don't respond, they have pinpoint pupils. We're going to administer that dose. We're going to remove it from the package. We're going to place the tip of the nasal applicator into one nostril, and we're going to firmly press the full dose into the nostril. Okay? Then we're going to call 911. Okay? Give a dose, then call 911. If we need to start CPR, we'll do all that stuff for them as well. We'll then administer additional doses after that. So every 2 to 5 minutes, we can give a new nasal spray, alternating nostrils. Naloxone is the most common one that we think about. It looks very similar to morphine. It has a lot of off-label uses as well, one of which is for opioid-induced constipation. Oral bioavailability is less than 2%, meaning when you take it orally, it's just going to stay in the gut and none of it's going to get into your bloodstream. So for opioid-induced constipation, naloxone is actually a good option. Okay. What are your observations when looking at our reversal onset peak half-life duration? You got someone that's minutes to death in front of you.
Takes 2 to 5 minutes for us to work.
Do we love it? Do we hate it? If we had to make our own drug, what's it going to look like? How's it going to differ?
Takes a while.
Last longer. We want it to work faster. All these things. So nalmefene is another option. It is higher affinity, so it's more magnetic to those receptors. And what do we see about these times?
Quicker.
Faster onset, much longer half-life, hours. Okay, the concerns with Narcan or naloxone is you give a dose, their opioid is still going to be working potentially after their Narcan comes off. This we don't have that concern as much. Okay? There's a lot of, I would say political questions, but political is not the right word. As far as, is this safe, or does this encourage people to use opioids illicitly? Because they know they can just take this and they'll be fine. Okay? My argument, and most psychiatrists will argue that no one wants to go through withdrawal, so no one's going to purposely put them in a space where they're going to go through withdrawal. One thing with this one is that it is only indicated for those that are 12 and up. When DHA Formulary Committee asked me, do I want to approve this, I said yes. I said other words than just yes, but I said yes. Unfortunately, others on the panel said no, because it's not indicated in those less than 12. My argument is that if it was my kid, and I got to pick between an onset of naloxone versus this one, and a duration of naloxone versus this one, I'd rather my kids start breathing sooner. Okay. So we'll pause there. Plan for 10 minutes, come back. I'm not expecting you guys to remember pathogens. Okay? However, if you know the pathogens, you know the mechanism and all the side effects. Okay? If you know that when we open it, it does that, but then we sit on it, it does that. You know what withdrawal looks like, you know what all the side effects are. Okay? So that's why I'm bringing it in this way, and how I'm saying it that way. But the questions will still say, this person is administered a mu receptor antagonist. What is the expected outcome? Okay, if you know the pathophys, you already know what that is. If you want to memorize what the side effects are of an antagonist, be my guest. Okay. I think we'll do a review at some point next week. Okay, so I'll do a review at some point next week.
I just want y'all, like, I'm never going to take y'all and just, like, push you out there and leave you by yourself. Like, I'm not going to do that, okay? So, I'm trying to make things better so that y'all can remember stuff and not, this was a lot less than what it was before. Granted, there's more slides, it's less clutter. It's less than 5,000 words per slide, which is typically what y'all are used to seeing. And this is what I'm trying to do to debulk the slides. So yes, it looks like the slide decks are more, and yes, now we have more time to slow down and give you more of that background information to say like, hey, all right, here, this is what this looks like. But the same things apply, like what is my drug, where's my class, what are my adverse effects, my interactions, like the same things that we always talk about are still there. My mechanism of action, all of those things are still here. It's just presented in a less cluttered way, in an easier way for you to remember. So I know it looks different, but I don't need y'all for candy. I will not hurt you, I promise, okay? I will not hurt y'all, all right? I know how y'all feel about that last exam, but I'm not gonna hurt you. It's gonna be a hurt.
I'm scared.
All right. So we just talked about some of our opioid antagonists and opioid use disorder. It's important that we think also about opioid risk mitigation. So how to minimize any potential risks that are associated with opioid use from kind of a misuse standpoint. Okay, where they're getting to that addiction, they're using it despite harm, those things. So we can do toxicology screens. Again, this is just going to tell us, is it in there, is it not in there, are other things in there? We can do a PDMP. This will be something that will be required, especially if you work at a military site, that you will have to do this. Typically your licensure requires you to have a PDMP account. You just type in a little search with the patient's name. It shows you all of the controlled substances that they have gotten. what pharmacies they've come from, and what providers have prescribed them. Okay, so that's helpful. Opioid agreement, or a sole provider, meaning that one person is the only person that prescribes those things. It's a contract. There's lots of different screenings that we can use for misuse, as well as to assess the efficacy that they are getting from these different opioids. There's a safety screen called the REASSORD, and that determines the likelihood that someone would have an opioid-induced respiratory depression event within 6 months. So you put in all these numbers, and it says, great, their REASSORD score is this, and the risk of an event is 56%. And then naloxone rescue, like we mentioned. So we have little Noah. He was found unresponsive with blue lips and fingertips and slow, shallow respirations. Pulses are present. Okay? If this was an exam question, you would add 2 more sentences to this to ask a question. Okay? So all of the patient cases are very much add 2 sentences, and that's what your exam questions will look like. Okay? They all have a mini patient case, not to distract you. But then I'll say, he's found to be having an opioid overdose. What is the best agent to use? Okay. Just naloxone?
Yeah. The other one's not for
Bummer. Okay. Alright, so the other one, he can't use OPVI because he is less than 12. Okay, back to Marissa. What risk mitigation and monitoring might we do for her? Right? She was the one who had hydromorphone that was present when it probably shouldn't have been.
check the BD&P if she got drugged somewhere else.
Yeah, check the BD&P. We can see if she got it filled somewhere else. Maybe do a contract. Okay, so you know what? I don't want you going to Dr. Smith. I'm your new favorite PA here in town. Good question. So within the military, I'll talk about at BMC. So ours is not a legal binding document. Okay? Ours is more of an educational thing that says, hey, you're on opioids. These are the things that you need to do. So you need to not give them to children, not give them to other people. You need to take them as I tell you that you can take them. And so it's more of a safety standpoint. If you lose them, we're not going to fill them early. Those types of things. But it's not legal, the one that we have. Sole provider is something that we do at BMC. Every single, how that program works, folks who are high risk are identified by a handful of pharmacists, and then they can be referred to the program, and typically their primary care doc sees them every single month and prescribes all of their medication. So even if they go to cardiology or rheumatology or wherever, one person does all of their meds, and that's because they've shown potential concerning behaviors in the past. We do have folks that, I wouldn't say that we've fired, but that's kind of the term that gets used when they're doing things inappropriately or unsafe. Typically, though, that's going to look like, right, so our gal who's like this today in clinic, and she's like, oh yeah, I got it off the street. Okay, it's not, well, not our problem anymore, sorry. And we then step in and say, you know what, I'm worried about you. I wonder if we can get you set up with this methadone clinic or with this addictionologist. We really want to support you. So we don't fire people like most folks think about doing. Really just trying to get them to the right resource, the correct resource. Good question. All right, starting from the very beginning. What do we use them for? Severe cancer pain. Okay, we can also use them ideally in procedural acute pain or in that serious terminal pain. We can also use opioids in dyspnea. How would they work in dyspnea? What is dyspnea?
Struggle breathing?
Difficulty breathing, right? All those things, okay? So shortness of breath. So how can we use an opioid to treat someone who's short of breath? Feeling like they can't catch their breath. Yeah, we're actually decreasing their respiratory drive. So we're not fixing their respiratory function, but we're telling the brain it's okay. So sometimes we can use opioids for that. We can also use opioids for cough. And so two of our opioids are going to be helpful for cough, which we'll talk about. They're going to be codeine and hydrocodone, nicely named. Both of them have C's, both of them used for cough. Love them. Okay? Diarrhea. Why can we use opioids for diarrhea?
Constipating.
We know it, right? Pathophys is what? Who means, huh? We already know how these things work. Okay? Lots of different formulations of opioids. Okay, we have tablets, capsules, solutions, we have patches, we can do injectable formulations. Many opioids come in either IR or immediate release, meaning you take it and it starts working. There are also extended release or controlled release or sustained release products that are going to be more long acting. As with any long acting formulation, you cannot split it, chew it, crush it, any of that stuff. Okay, once you do, then it turns into immediate acting. So we don't want to do that. Long-acting products as well should only be given when folks are tolerant to opioids. They've been on short-acting, their body's used to opioids, now we can put them on a long-acting. So then really, how do we use these? So last month, the FDA said, you know what, we're not really sure if we should be using these. Okay? So their long-term use, they said, yeah, we're not sure. Right? Day one, I said the typical pain trial was about 6 weeks. So the FDA finally cut up to that and said, oh yeah, it is only 6 weeks. We're using these for a long time. They wanted to have some clarity in the dosing and the warnings. They wanted to revise guidelines about how to appropriately use opioids, more education, all of those things. So again, this is not a testable question on this slide, but it's to let you know, right, that we really don't know how these things are working, how safe they are, where their place in therapy really is, except for severe cancer pain, acute procedural pain. You got it. Okay. So we're going to run through some of the highlights with each of our opioids here. Heroin is a C1. It's going to be more potent than morphine. It has no medical use indication. It is an illicit formulation, and as we already talked about, heroin goes to 6 a.m., goes to morphine, and it can accumulate in hepatic impairment. Meaning, if someone has hepatic impairment, they're at risk for what? Overdose of death. Okay, that's all that means. Okay, codeine. Codeine by itself is a C2, with Tylenol is a C3, with florpheniramine is a C5. It is a weak mu-opioid receptor agonist. It is less potent than morphine, meaning you need more of it to get the same effects as morphine. It works for pain, but it does also have that cough suppression off-label indication. It's going to be given as an immediate release formulation orally. It is contraindicated in those that have different types of asthma conditions. So one of the things that is within it is actually a respiratory irritant, which I always think is interesting because we use it for cough suppression. Okay, so just be mindful of your population that you're picking for that. So if someone does have asthma that we're using it for, we're going to use our other opioid as an antitussive. As we already talked about, codeine has that 2D6 ultra-rapid metabolizer, and so being mindful in our kiddos, in our breastfeeding moms, that we're going to avoid or potentially never use codeine. Morphine is a C2, often called MS, or morphine sulfate. That is one of the unapproved abbreviations for joint commission, because folks are getting it confused with magnesium sulfate. Its primary mechanism is going to be at the mu-opioid receptor. Right? Both doors are fully opening. It's going to work for pain. Oftentimes we use infusions within the ICUs. We can use it for dyspnea as well. Because of how well it works at mu, we get a lot of that histaminergic release. So oftentimes we'll have patients that complain of the itching, of the rash, of all of those things with morphine. Okay. much more prevalent. There are 2 additional metabolites of morphine, M3G and M6G. M3G has a little sad face next to it, and it causes a bunch of CNS issues. How many letters is CNS? 3. Which metabolite causes that? 3G. Okay, so CNS effects with M3G. M6G is active and it actually provides more pain relief. Hydromorphone is another metabolite, it also gives pain relief. We love that. Metabolites do accumulate, and it does have an additional box warning when used with alcohol, or the ER, the extended release formulation. Morphine's one that's really pretty, it looks like candy. That's also why it's horrible. Lots of kids can get into it, and that's not a good outcome. All right, hydrocodone is metabolized from what drug? Codeine goes to hydrocodone, goes to hydromorphone. Love it. Okay. It's going to be oral. It can be used as a cough suppressant as well. We mix it with a bunch of different things. So the only time that it's by itself is when it's long acting. We don't have a hydrocodone that's just hydrocodone IR. It's always going to be mixed with something. Oftentimes Norco or Vicodin, so when it's mixed with Tylenol, these are the most common products that we see there. And then this one has accumulation with our 3A4 inhibitors, or G-Pac-Man. We're going to increase that concentration, increase our risk of overdose and death. Again, all this stuff that I'm expected to know, I've already shown you kind of at the front end, right? What were the ones that went through 3A4, what went through 2D6? Hydromorphone is a metabolite of morphine. Hydrocodone. Codeine. Heroin. I love this. You guys got it. Okay, it's also going to be more potent than morphine, meaning you need less of it to get that same effect. Also going to be used for pain. We can also use it in our ICU, especially for our vented patients. This is definitely one that is preferred. For oral, we have IR and ER. Dilaudid is a very common brand name that we use for it. Just like morphine had M3G, hydromorphone has H3G. What kind of side effects does that cause? CNS. Oh, got it. I love this. Okay, so CNS side effects. Okay. Renal and hepatic impairment are other concerns that we think of. Going to our semi-synthetic opiates, oxycodone is going to be more common. Oxymorphone is available. We rarely see it used. I did not add a slide for oxymorphone. So oxycodone is a C2. It has additional activity at serotonin. Okay. So side effect wise, what things might we see? Serotonin syndrome. Okay. Comes as oral, IR, and ER. It comes either by itself in IR or with Tylenol. ER is marketed as a 12-hour, though it has a half-life of about 4 to 5 hours. So oftentimes what we see when folks are getting this is they get what's called end-of-dose failure. Meaning they take a dose of Oxy 20 ER, and then at about hours 6 to 8 to 10, they're feeling that pain again. Okay. So how do we treat that? Do we increase the dose? Increase the frequency. Okay, so instead of doing it Q12, if it's failing to meet that cutoff towards the end, we just dose it Q8 or Q6 or however much we need. Okay? So we can increase that frequency. All right, renal impairment, hepatic impairment. It does have a 2D6 metabolism to oxymorphone, and it does also have 3A4 inhibitor side effect as well. Oxycodone is going to be the one that is our main driver in much of the opioid epidemic, right? Purdue Pharma, I'm sure you guys have maybe seen or heard of some of the many TV shows, series that are out there, jokes like those types of things. Very interesting things that oftentimes the patients will ask you about. All right, we got Kevin. He has an upcoming elective painful surgery. He has a historical reaction of itching with morphine, and he wants to ensure that his pain can be well controlled intra and post-operatively without worsening his general tolerability. Okay, potentially you can add an antihistamine. Okay? Anything else we can use? The ones that we've talked about, right? I'm not trying to have you guys be fortune tellers. Maybe hydrocodone, I hear. Okay, what else?
Oxy.
Maybe some of our oxys, maybe hydromorphone. Okay, but we want to avoid morphine. We also want to avoid what other one? Codeine, right? Because codeine's going to go to morphine. Obviously, we're going to avoid heroin. I don't know where you guys want to work, but that's somewhere, okay? So we can maybe use some of our oxycodone. We can maybe, just treat those symptoms, right? Give our antihistamine, and potentially use our oxycodone. All right, Miss Anna, she's a 33-year-old female. She has new onset cough associated with suspected viral illness, and she's looking to suppress the prevalence in the short term. What ones are we going to avoid?
Morphine.
Well, I can't show that. Let's say, yes, let's assume she has pumped, she is now feeding breast milk to her child. Okay, potentially no opiates, deal with it. Have some Teslamprol, love it, okay? If she's like, no, I tried Tesla, it's not helping. This one time I tried codeine with cloth medicine and it worked wonders. I felt great, slept wonderfully. You bet you did. You bet that you did, okay? So the concern is, why can't we give her codeine? Yeah, she's a rapid metabolizer. Then she has what metabolite? That's in there. So we have codeine.
Morphine.
Morphine. Okay, so we have a ton of morphine, right? So ultra rapid metabolism. So we have codeine. Normal metabolism would say, okay, a little bit goes over here, and then that goes everywhere else. A little bit comes over here. Ultra rapid is we have this huge shift, and now we have much more of the amount that we thought we would have. Okay, so we have a ton of morphine. Okay? When we breastfeed or pump, the concern is that now we have a bunch of morphine in that breast milk. If we're getting that to babe potentially is going to demonstrate what signs? Respiratory depression, sedated, all those things, and then potentially death. Okay? We don't want to do that for Anna. We're better than that. What other product might we avoid? Tramadol. Okay? So both of those are going to be our 2D6. Alright. Fentanyl, we got a couple slides on here. Fentanyl is a common one that we'll see. Fentanyl also has serotonin activity. It is much more potent than morphine. It is synthetic, meaning it is made in a lab. They're all made in labs. Let me paraphrase. Okay. But it is not opiate-like. So if someone has a true allergy to one of our ones that we've talked about already, right? This one's in a completely different thing. That cross-reactivity is very, very little. Okay, completely different chemical structure. Not going to have that interaction. We're also going to use it for pain. We can use it up in the ICU. We'll see it a lot for rapid sequence intubations as well. It comes in an injectable. That's going to be for our acute uses. Okay, so ICUs, RSIs, those things. We also have a transdermal patch, or Duragesic. That is going to be a chronic and it's continuous use. is how that is getting infused. We used to have a lot of other products, so fentanyl lollipops are kind of a joke that folks talk about. We used to have them. Okay, about a year ago, the manufacturers said, this is too much work, FDA. You're asking us for too much. We don't want to do it anymore. We're just going to take them all off the market. Okay? So really unfortunate for our folks that were relying on that. So a lot of our folks who are on hospice that found great benefit in those different products. It is very lipophilic. So patients who are cachectic, meaning what? Super, super skinny, no fat is on them. Okay? It might take time for it to start working in them. We want it to get into that fat tissue, get working throughout the body. We have a box warning with our 3A4 inhibitors as well, increasing that overdose risk. The fentanyl patch should not be started on someone who is opioid naive. Fentanyl patches are clear, and they should never be cut. If you cut a fentanyl patch, you can have dose dumping, where a drug that would be slowly infusing over a couple days is all going straight into the body. What's that a risk for? Overdose and death. Okay, you got that. Because they're clear, you can tape around the edges so long as you can still see that it says fentanyl or Duragesic or whatever it is on the label. Or you can put a whole clear bandage over it. Okay, but you can't put a normal Band-Aid over the whole thing. Why not? We need to see it. If you're in a car accident and we see you, I'm not gonna like rip off your Band-Aid to see if there's something there. Okay? Maybe we would. I'm not EMS. Okay? Dosing. So the lowest dose that we have is a 12 microgram per hour. The highest that they formulate is 100. We have folks in clinic who are on 300 plus. So it really just depends on the person and what they're going through. Again, those patients are folks that have very terminal, very significant cancer metastases. It is dosed every 72 hours. However, we do find that sometimes we need to go down to 48 hours for that dosing interval. Okay, because of that end of dose failure. Fentanyl patches can be applied on the outer arm, across the chest, across the upper back, or kind of on the side or around the flank area. It takes about 6 hours for them to start working. So when you put a patch on, are they still going to be in pain?
Yes.
Yes. Okay? How long until they start getting a good feeling from that? 6 hours. Okay? Once we take a patch off, then what?
That keeps working for a while.
It's going to keep working for 6 hours. Why? So it takes time to absorb through the skin layer to get into that systemic circulation. Okay. So that's a problem with fentanyl is that, unfortunately, that it takes time to start working. But the benefit is that even if you take it off, you still get that benefit for another 6 hours, unless you're at risk of overdose. And from our standpoint, we need to make sure that we're treating them appropriately for the appropriate amount of time. Take off that patch, keep monitoring them, because they're still going to increase that absorption during that window. When you take off a patch, you should fold it in half and flush it down the toilet. The EPA is fine with this. That's with any of our controls. Okay, it's in your water supply, it's fine. Fold it in half, flush it down your toilet. If you don't want to do that, I have a couple old guys who are like, not in my septic tank. Sure thing. Put it in a lockbox, bring your lockbox into the pharmacy or wherever there's a take-back bin and dispose of them in there. They should not be thrown away. There have been numerous cases of kids, of pets, getting it, chewing on it. 70% of the drug is still within the patch when it's taken off. What's going to happen to those kids? Overdose and death. Okay, straight on the mucosa, not good outcome. So flush it down the toilet or bring it back to a drug take back then. Fentanyl patch also do have increased absorption with increased heat. Where else did we hear about this? All of our topicals, right? Catches and feels more. Okay. So all of our topicals, the more heat that we have applied, the more of that systemic absorption that we're going to get. So if someone's fevering, we can actually have an acute intoxication and potential overdose. We have one gentleman who feels so great when he works out. Okay, he has fentanyl patches. You know what? Oh yeah, I just feel really good. My pain's controlled. Like working out is great. Right? But I would love for working out to be the reason why he feels good and refreshed every day. It's probably because he's sweating. He's getting that energy up, and he's getting more absorption during that time because he's warmer. There are fentanyl derivatives. There's many of them. Two that we'll talk about, sufentanil is much more potent than working as well as fentanyl. It comes in a sublingual tablet as well as IV. It also, just like fentanyl, is impacted by our 3A4 inhibitors, and it increases our overdose risk. And then we also have remifentanil, which is equally as potent as fentanyl. The benefit with remifentanil is that it has a very, very rapid onset and short duration. So it's a wonderful agent for a very quick procedure. Okay. It's metabolized within the blood. So it doesn't have to go through the liver and all those other things. So that's why that one doesn't have the same impact of our CYP enzymes. Loperidine has anticholinergic activity. It has dopamine, norepi, 5-HT activity. It also is a sodium channel blockade. Primarily, it's not going to be used in pain. And that's that red box right there. Placement therapy, we don't recommend it as a pain med. Where they do use it is for post-op shivering. So some of the medications that they give during surgery can cause folks' body temperatures to decrease and cause more shivering. So meperidine can actually be used there. How we remember meperidine or Demerol, again, on your exams you're going to get branded generic, is dump Demerol. Okay, just throw it away, dump it. At least for me. Okay, tramadol is going to be one of our C4s. It is a weak V receptor agonist. It also has serotonergic activity. It is synthetic and less potent than morphine. We can use it for analgesia. We can also use it for premature ejaculation. Why is that an indication? What mechanism?
It represses those sympathetics.
So serotonin, think about our antidepressants. A lot of our antidepressants cause sexual dysfunction. So if someone's overly active and we want to cause sexual dysfunction, we can actually give tramadol because of how much activity it has at serotonin. Tramadol, I think, much more as an antidepressant with its serotonergic effects and norepi than I do as an opioid. We have our 3A4 and 2D6 with this one, and then be cautious in renal. We're going to meet Josh here, and then we will call it for today. So Josh is our 34-year-old. He cares for his elderly mother, who's actively receiving the supportive hospice. Her pain is well managed with the use of fentanyl patches and concentrated morphine solution. He's excited that grapefruit will be in season shortly, and it's a treat that she always loved.
Stop.
But his mother.
Does she like pain relief or does she like grapefruit?
Right. So why is this a concern?
Pain symptoms.
Yeah, G Pac-Man, right? That's our G, right up front, right? You know what, Josh? I'm glad you're here for your mom. How about we try some oranges? I love that idea. I think she loves, a lemon or lime or something. But let's avoid the grapefruit right now. Okay? Question? All right. One more thing from Heart.
I have a question for y'all. We're talking
the two
So,
options,
yeah, your two options are we keep going and you'll.
Can you put the speaker on?
yeah, so the two options, one is, so this lecture, and then the go. Alright. So, we'll push on. Alright, so Josh. We're gonna move on to methadone. Methadone is we've already talked about methadone once before. Where else does it have a place in therapy? Oh, you did? Opioid use disorder. Okay. And how's it work? So full opening, right? So methadone fully opens. What's bupe do? One, right? And what's our injection? Okay, naltrexone or injection blocks it. Okay, those are free for OUD. So methadone is agonist at all three of our opioids. It's also an NMDA antagonist. Okay, we've talked about a lot of different things that are NMDA antagonistic. It also is a 5-HT and norepi inhibitor. So it also has kind of antidepressant effects. It's more potent than morphine. We use it for pain. We can use it for opioid withdrawal. Okay, so typically the situation, someone uses heroin or illicit fentanyl. They come into the ER, they are withdrawing. We can give them methadone to help them through that. The benefit with methadone is it has all those other mechanisms. Okay, so you're not just resupplying that exact same mechanism, you're adding additional mechanisms. We can use it for that opioid use disorder, but again, if it's solely for that opioid use disorder, if that's the indication, they must go where? A treatment place. Okay, the outpatient treatment programs. We have oral, we can also do injection. Its half-life, 8 to 60 hours. Any furrowed eyebrows like, what? Right, huh? Okay. So the longer we use methadone, the longer the duration, the more, arrows here. The half-life increases the more that we use it. Okay? For pain, to get pain benefit, typically the duration we see is 3 to 12 hours. Okay? Opioid use disorder, though, you're only going to the clinic once a day. So for cravings, we see that that duration is much, much, much longer and aligns much more with the half-life. Specifically for pain, though, we're at that 3 to 12 hours. So oftentimes we need to dose it every 8 or every 12 hours. Its peak effects, unfortunately, are going to take 3 to 5 days of continuous use. Because of the delayed steady state, whenever we change a dose, we have to wait 3 to 5 days. Okay, it's going to take time for it to get up to that new steady state as far as what's going on. It's a long-acting opioid naturally, just given how long its half-life is, and so we have less withdrawal from it. When someone misses a dose, they really don't feel it. They don't have, all of a sudden they have a ton of diarrhea. So that is a benefit that we love using methadone for. Its dosing, I talked to my PA as far as what to share with you guys. I went back and forth on it. The bottom line, it is very complex, and ask an expert. Start low, you go very, very slow. Typically you're changing that titration every 5 to 7 days. Your pain dosing is considered to be more of a low dose option, often no more than 30 milligrams a day. OUD, we have doses from 15 to like 1,000. I hate when the ICU calls me to ask for my opinion of someone who's using illicit opioid to help pick a dose for them. Very, very confusing given its very long half-life. Methadone solely has inactive metabolites, and it is metabolized through dang near every CYP enzyme, meaning that inhibition of any of those enzymes will increase the concentration of methadone, which will increase overdose and potential death. Okay? Methadone also has risk for serotonin syndrome, given its mechanism. It also has QTC prolongation that is dose dependent. So the more or higher your dose, the more likely they're going to have more of a QTC prolongation. As with any QTC prolonging things, you have your same cautionary tales, right? So if they have electrolyte abnormalities, they're going to be more at risk, all those cases. We monitor their pain for CNS, blood pressure, glucose, all these different fun things. But bottom line, methadone should not be a first-line option. Okay? Only clinicians who are familiar with it and its unique risks and are able to educate and appropriately monitor, right? Because we have that delayed effect, as well as that QTC, should be considering prescribing methadone. So let's meet Kenny. Good, I have someone in their 70s. So he's admitted, and he has a pain exacerbation. He was previously managed with methadone 5 PO/TID. Despite increasing the dose yesterday to 10 PO/TID, his pain is still poorly controlled, and so the team decides today to increase it to 15 PO/TID. We haven't reached steady state. Team, what are we doing? Okay. Unfortunately, cases like this happen all the time. The concern, right, even if Kenny is fine and we keep him at this dose, likely when he reaches steady state in a couple days, he's not probably going to get there. Okay? The concern is that how quickly we escalated, potentially he would have an overdose event, it would likely be cardiac driven, and he would die.
Take him back down to 5.
The dosing that we typically use, again, I didn't want to get into this for your guys' sake, but the dosing just for a benchmark is no more than 5 milligrams every 5 to 7 days. So the first titration was already 15, and then we went up another, right, the day after. The biggest thing, you always need to wait. Methadone is very unique compared to the other ones because the doses seem so small. And so we feel comfortable that it's just going to be linear, we can just go for it. We do that with morphine, with oxy, all these other things. We can do it one day, the next day we can change it. Methadone, not so much. Methadone is going to take time. We need to get to that steady state. All right, our other unique opioid here is buprenorphine. What did we already say we could use this for? Opioid use disorder, how so? Partial. We got it. Did some kung fu. Okay. So we're a partial at mu. Okay. We have an additional mechanism.
Inverse course.
So an additional mechanism here, when we have a normal full agonist opioid, it binds to the receptor and we get this little phosphorylation tail. This tail is responsible for a lot of our side effects. When bupe binds to the receptor, it does not have that same tail. It doesn't have that same recruitment. Right? So we have less side effects just because of that. Am I going to ask it on the exam which one has less phosphorylation of its side effect tail? No. What question will I ask? What is the mechanism of action? Okay? What are the side effects profiles? Okay? But this is the rationale why, right? It has the strongest affinity. So that bottom chart there, right? It's the most magnetic to that receptor. That means that it can kick off other opioids. So if someone has heroin or fentanyl or something is in their system, and their doors are fully open, and then we give them this other one that's a partial, they could go through withdrawal. Because now we're not stimulating that whole field again. Okay? We're not giving them all of those same effects. We're only doing it kind of. So they can get a withdrawal if they're currently stable on an opioid and we switch them right away. So we do need to have them go through a slight withdrawal before we put them on buprenorphine. Bup also has an antagonist at the delta receptor and then is an inverse agonist at the kappa. So we have less that kind of CNS concerns there. Mechanism, because of the partial, we have ceiling effects. So it's that modulation. We have or moderation. We don't get as much respiratory depression. We don't have that same level of overdose risk. We have less of those long-term side effects because it's a partial. For the guidelines from the BABOD, if we had to start an opioid, we should start Bup. If they had to get a daily opioid, the preference would be to pick Bup. And that's because of those beneficial ceiling effects for that side effect profile. Beneficially, we don't have side effects noted or a ceiling effect noted for pain relief or for pain benefit. So we can keep treating them, they'll still get that pain benefit. There's tons of formulations. We can have it by itself or we can mix it with something else. When it's mixed with something else, what is the purpose of having naloxone in it? Okay, misuse, how so? Okay. So specifically opioid misuse. How so? We're taking an opioid.
Just decrease the amount of bind sites.
Yeah. Often if you're going to misuse one opioid, you're probably going to misuse other opioids. Okay? So while it might not counter the effects of Bup, hopefully it's going to counter the effects of heroin or some other things too. So it's a way to have an abuse deterrent. The only two that are indicated, or primarily indicated for chronic pain, are which two? And what's unique about them? B-trans and Belbuca. And what's interesting? Now there's some weird dosage ones, but their units are in micrograms. Everything else is in milligrams. And we'll go through each of them here. Just the All right, bioavailability depends on the formulation. Okay, that's all you need to know there. The formulation also depends on what we're using. Because of its affinity to those receptors, remember that it could kick something else off. And it does have different metabolism pathways. It does have active metabolites. So when looking at the B-trans patch, in pain clinic, the majority of our folks who are on opioids are on the B-trans patch. Again, these are micrograms per hour. This is a weekly patch. Because it takes time to get to steady state, we can't change it any sooner than every 3 days. So if they still have pain, as long as it's been 3 days, then we can titrate it. Same sites that we apply a fentanyl patch to. How often do we change fentanyl patches? 72 hours. Okay, fentanyl patches are every 72 hours. Bup patches are every week, every 7 days. They are more of a fabric type patch. So fentanyl patches are clear, these ones are more fabric based. They also have the drug stated on there. And heat with this one is also an indicator that we will have increased absorption. Belbuca, another one that's in micrograms. These are going to be buccal films that you place onto the side of your cheek. When you place them, you cannot eat or drink for 30 minutes. Okay, that can decrease the dose by up to 20 to 40%. Typically, we're going to use these every 12 hours. Belbuca, interesting thing here is that the sizes of the films are not linear. So we have a 1.2 to a 2.4, and then 300s all of a sudden go to a 0.9 area. So this is something that I did not know until a patient was really demanding, no, I need the 150s. I can't use the 300s, which to me sounds like, why are you trying to get more product? Right? So always being sure that we're aware of our biases, especially when it comes to opioid therapy, looking up stuff that doesn't make sense, and that yes, the 300s are significantly smaller than the 150s. The foils are color coded, so we know which one or which dose they're getting. And then Suboxone is mainly going to be used in our folks that have opioid use disorder. It is dosed in milligrams. It is often placed as a sublingual film under the tongue. All right. So this chart here shows our daily dose that we're using of mu. Okay? And of those doses, how much of our mu receptors are occupied. We know that in order to get pain benefit, we really only need to occupy about 5% of the receptors. Okay? 1 milligram is already 20-25% of that. Okay? We only need 5. So to get pain benefit, we can do what? We can use low doses, because we don't need to occupy as much of those receptors. If we need to inhibit cravings though, if we need to block the effects of other opioids, we need to occupy a lot more of those receptors, 50 to 80 plus. Okay? We're going to see that once we're getting into our 8, 16, 32 milligram a day dosing. Okay? So for pain folks, if we're taking microgram dosing, and we're only getting, at less than 5% or 5%, this suggests that we can still use other full agonist opioids in conjunction with our bu. Okay, so anyone who's on lower doses, so specifically the guidelines throw out 16 as that cutoff, we can still use other opioids with it. So an example, someone's coming in to get surgery. First thing we need to know is it a painful surgery or is it a painful surgery? If it's not painful, keep doing what you're doing. Okay? We're not going to give you any other opioids while you're here. You're fine. Okay? You're getting a mole removed, go for it. If it's painful and it's low dose, it's fine. We don't have to change anything. Okay? If it's low dose bu, we don't have to change any of our dosing, because the opioids that we'll give you are still going to be effective. If you're on doses over that 16, if it's emergent, we need to figure something out. If it's an elective thing, ideally we're going to work with your bu provider. Maybe that means we reduce your dose down to 16. So then when you go into surgery, it works for you. Oftentimes what we end up doing and what our anesthesia docs are doing, they are just giving a ton of opioids to these folks, trying to overcome the effects that bu is partially sitting on. Okay. All right, so what's the takeaway here? Because these are confusing slides. What do we use for pain? Low dose. Okay. If we use low doses, can we use other opioids?
Yeah.
Will they work?
Yeah.
It won't block them?
No. Not entirely.
Not if it's low dose. Okay, if we're at high dose and we're getting a lot of this blockage of other opioids, right, over 80%. So we really need to be above that 16 milligrams. Okay? As long as we're less than that 16, we shouldn't be blocking the effects of other opioids. Okay? monitor for similar things. It also has QTC prolongation that is also dose dependent. So we have good old Noah here. He has opioid use disorder. He is on Bupe, and he's scheduled to get a colonoscopy because there was an early polyp that was identified among an immediate family member, and he is not happy about it.
He's about to have a bad time.
Yeah, he's good. So why? We don't even know what dose he's on. Yeah, we do.
24.
24. Okay, high dose, low dose.
The high dose.
High dose. So what do we have to do?
You know.
Yeah, it's not a painful procedure. Mentally, maybe.
Oh man.
But he's not expected to get opioids during the procedure, and so we're not worried about having effects being blocked. Okay, so again, if this was an exam question, there'd be the 2 more sentences saying this is considered to be a non-painful procedure. What do we need to do to manage his Bupe therapy at this time? Again, if you know the pathophys and you understand the pathophys, hopefully that you'd be able to understand that. Or you can look back at the last slide. Okay. Opioid dosing considerations. So there's a couple terms that we use frequently when we're talking about opioids. So around the clock dosing or basal dosing is all the time, right? Every 2 hours, every 6 hours, every 8 hours. It's going to be a regular scheduled patterned approach. I like to think of this as my ocean. Okay, you always got pain, it's always right there. Okay. When you get a wave every now and again, that's what your as needed dosing or your bolus dosing is. Individuals that have around the clock dosing should also be given a PRN dose, okay, to help cover when those waves come in. A total daily dose, or TDD, is just calculating the 24-hour dose that that person got. Okay, the total daily dose. Continuous dosing is just something that's given at a consistent rate. This could either be infusions or patches. If it's one of our infusions and it's bedside, we'll have it in a lockbox. And then we can actually do, in addition to an infusion, we can have it be a patient-controlled button that they press. The provider, so you guys get to pick what that limitation looks like. So you get to pick what that dose is. Okay, if you want it to be 0.2 or 2 or 20, you get to pick how much of that drug is whenever they push that button. And then you also get to say how often or what that lockout is. Okay, so if you want it to be 0.2 every 10 minutes, that's what your order is. Okay, so that's a PCA. There's going to be some sort of infusion pump that has that demand dose. It doesn't have to have a continuous rate with it. It can just be a push dose. This would be helpful if your nurses are getting overwhelmed trying to give someone med if they're asking for it, every 30 minutes or something. It might be helpful in that situation to minimize that nurse burden, help them figure out what they're using. Certainly if folks have cognitive function issues, dexterity issues, visual impairments, if they don't know what this button is or what it means, or if they're like, oh, the button turned green, I pressed it, probably not the best option for them. When we talk about opioid dosing, we try to solidify it all to the same agent, and that same agent is oral morphine. Okay, whenever we talk about our drugs and their doses, we say, yep, this is how much tramadol is equivalent to blank amount of oral morphine. The units that we use are often going to be MEDDs, so morphine equivalent daily dose, MEDs, MMEs, OMEs, they all mean the same thing. So how much oral morphine is that dose of opioid Y to morphine? There's no single method to do this. I'm going to you're literally giving us one single method. I know. So there's no single method. For purposes of the fact that you guys have an exam, I will give you a method. Know that it is not the only method. Okay? Caution with calculators that are online, and then know that these are only estimates, and you still need to evaluate. What is the patient's QTC? What is their respiratory drive? What is this? How is their renal function? How does that impact this opioid or that opioid? They're going to get this antibiotic, that's a drug interaction. Okay? Okay, so you still need to coordinate based on those things as well. So this is an example of an equivalence chart where we have our dose of oral morphine there kind of in the middle, that 30 milligrams. Okay? And then we have equivalent doses of each of those. So we have codeine is 200 milligrams is equal to morphine 30 milligrams. So codeine and tramadol are less potent, they are weaker than morphine. And then our other ones on the bottom there are more potent than morphine. We can also calculate what these things are. So we can look at it and say, great, morphine IV to PO, IV is 3 times more potent than oral morphine. Okay, hydromorphone PO to morphine is 5 times more potent. Oxy 20 to morphine 30, that's a 1.5. So it's just another way to think about it. There may be charts that tell you what the conversion factor is, which would be a chart that has this 5, 3, 1.5, all of those things. I often recommend that you guys focus on equivalence charts, which is what this is in the background. Okay, it's the equivalent dose between different products. On the exam, you guys will have one question that asks you to do a conversion between these things. We'll go through a few here in a second. You will be given the chart of the drugs and then what the equivalent doses are. Okay. So you'll be given the chart minus this column. Fentanyl's highlighted because fentanyl doesn't come in oral anymore. Transdermal fentanyl is dosed in mg per hour. A general way that we can do it is by doing a factor of 2.4 to 4. So if someone is on a fentanyl patch of 25, we can multiply that by 2.4 to 4 to get our oral morphine equivalence of 60 to 100. We can also do it backwards, and we can say, okay, a fentanyl patch, or if someone has 100 MABDs, oral morphine, what fentanyl patch should we pick? And we can just do the opposite and divide it out. Fentanyl will not be your test question. It is confusing. Methadone. Use particular caution with methadone dose conversions because methadone has a long and variable half-life. It also occurs days later. We already learned this. So methadone does not have a dose conversion. I would recorrect that and say DHA has a dose conversion for methadone. It is not safe to use it. CDC and their new guidelines do not have one.
What is this?
Bupe is another one that doesn't really follow that linear thing because it's what type of action? Partial, okay? So general estimate is that the patch is going to be somewhere less than 80. That film, that microgram film is going to be that 80 to 160, and then the tablets are going to be greater than 160. And we're so close, guys. Do we want to stop here? Pick up tomorrow? No, absolutely not. We're okay. Mike, 37-year-old male. He's on Oxy IR 10 milligrams Q4. Yesterday he got 4 doses. How much Oxy did he get?
40.
10 Q4, he got 4 doses. So 10
40
times
milligrams.
4. We got it. So he got 40 milligrams of Oxy. We don't talk about things in Oxy. We talk about them in what?
Morphine.
Oral morphine.
1/4.
60. Very nice. Okay. The other good thing about using equivalence charts is that you can look at the chart and see, oh, Oxy is 20. Well, this person just got double that. So you can go up to morphine and still that one. Okay? So 60 is going to be our dose here.
That's the chart that will do.
Yes, you'll get a chart that looks like this one.
Okay.
Can you go back real quick?
Sorry, yeah.
Thank you.
Alright, a caveat is that whenever we transfer from one opioid to another opioid, we expect the new opioid to work better. even if they're in the same family. And so that concept is called this cross tolerance or incomplete cross tolerance, where we still have activity even though we've been on morphine for years and years and years. Even if we go to oxy, we still think oxy is going to work. We don't think that they're just it's not going to work because they've been on opioids forever. It's a different chemical, it works in a different way, meaning that when we go from one to another, we need to dose reduce. But dose reduction on the exam would be given to you. Okay, it would say please dose reduce for cross tolerance by 20%, 50%, whatever it is. Okay? So as an example, if we have Dave, we'll walk through it. We have Dave. He's myofascial low back pain. He's given hydrocodone with Tylenol, and it's less effective than it used to be. So what condition is he likely experiencing? His tolerance, okay? What is his OME? His MEDD? Hydrocodone 10 Q6. So he gets 40 milligrams of hydrocodone. Okay, 10 times 4. So 40 hydrocodone. What if we wanted to switch to oxy? Is it going to be a bigger number or a smaller number? Smaller number. Oxy is more potent. Okay, we can also use the, look at the table. So good as the slides are, what do I do? Oh, you know why? Because I'm getting ahead of myself. That's why. So that's the next question. Okay, we want to switch into oxy. We're going to take our morphine. We're going to do the opposite. Okay, so doing our conversion one way, we'll do the other way. I will probably plan to come back tomorrow and do this part again, just for the first 10 minutes. Okay. In this scenario, I was asked also to dose reduce. Okay. So here we can convert to oxy. We get that 26.6 of oxy with a 25% dose reduction. That's how we get that 20 of oxy.
What is the 325? 10 over 325.
That's the amount of Tylenol that's in it.
Okay.
Good question. All right. I think we're going to pause here, and I'll just take the first 10 minutes tomorrow to wrap things up, go through these pieces again.